Hello, Dr. Powers. My name is Duncan and I'm a pharmacy student. I'm here to talk about the GLP-1 use in pediatrics for your clinic visit tomorrow for the 10-year-old patient, Abigail Lincoln. Her birthday is 7/16 of 2024. Abigail is a 10-year-old female with a height of 4'6" and a weight of 187 pounds. Her BMI is 45.1, and this places her in the severe obesity category in the 99.99th percentile. She was diagnosed with obesity at the age of 7, and her family history includes obesity, type 2 diabetes, and hypertension. She currently has no other significant medical comorbidities, but her blood pressure is borderline at 120/80, and she has a fasting blood glucose of 102 at her last visit. She has no history of eating disorders, but reports occasional emotional eating related to stress at school. Abigail is being seen for her routine follow-up for weight management. Her weight has been steadily increasing over the past year despite interventions of dietary counseling, physical activity recommendations, and behavioral therapy. Her parents also expressed concern about the patient's ongoing weight gain, self-esteem, and social isolation from bullying at school. Abigail also experiences difficulty engaging in physical activity and has noted increasing fatigue and joint pain. A study called Liraglutide for children 6 to less than 12 years of age with obesity, a randomized trial, looked at Liraglutide use in children aged 6 to 12, and the children were randomly assigned to two groups in a 2-to-1 ratio. 56 participants were assigned to the intervention of 3.0 milligrams, or the maximum tolerated dose, and 26 participants were assigned to placebo. Both groups received lifestyle modifications throughout the trial. And then eligible participants in the study were children aged 6 to 12 with obesity, specifically age-adjusted and sex-adjusted BMI in the 95th percentile or higher, according to the CDC, is what they used. And then they also had to be Tanner stage 1 through 5 without type 1 diabetes or secondary causes of obesity. The primary outcome of the study was a BMI change at 56 weeks, and some secondary endpoints of the study included change in body weight at 56 weeks and a reduction of BMI by at least 5%. Adverse effects incidence was also evaluated by looking at any adverse event in both groups and GI adverse events in both groups. This study was a phase 3A, double-blinded, randomized, placebo-controlled trial at 23 sites in 9 countries. The results of the study included 5.8% reduction in BMI in the liraglutide group and a 1.6% increase in the placebo group. The mean percentage weight change in the body weight was an increase by 1.6% in the liraglutide group and an increase of 10% in the placebo group. There was also a reduction in BMI of at least 5% in 46% of participants in the liraglutide group and only 9% of participants in the placebo group. Our patient does fit within the confines of the study since she is between the ages of 6 and 12 and has a BMI above the 95th percentile and doesn't have type 1 diabetes. We don't really know her Tanner score, but she likely fits within stages 1 to 5 based on her age. And she has also tried different lifestyle modifications without results. This study was well performed. It was performed in 9 different countries at 23 different facilities. It evaluates several endpoints, including adverse events that do not favor the intervention, which shows that it has limited bias. However, there isn't a lot of information about what the term any adverse effects includes, which could be a weakness. And then it was also a small sample size, but ultimately was sufficiently powered for what was being measured since differences were noted. The confidence interval for the 3 endpoints were all at least 95%, and then the study is also funded by Novo Nordisk, which could lead to some bias, but it's pretty normal to see this, especially since it is a phase 3A trial. The results are consistent with other trials referenced by the American Academy of Pediatrics in their clinical practice guideline for the evaluation of and treatment of children and adolescents with obesity. However, the American Academy of Pediatrics makes no recommendation on the use of GLP-1s under the age of 12. Based on the patient's history of attempting to control weight with lifestyle modification and the contents of the study, I think she is a candidate for the liraglutide. The study addressed starting at a dose of 0.3 or 0.6 milligrams, depending on weight. Since she is over 45 kilograms, I recommend that she starts at a dose of 0.6 milligrams injected subcutaneously every day, and then the dose can be increased by 0.6 milligrams each week up to a dose of 3.0 milligrams based on her tolerability. And then also based on the trial, she should also continue to adhere to lifestyle modifications on top of the liraglutide. And then the patient should be seen weekly in clinic after to modify the dose and ensure the patient is tolerating the medication. At each weekly visit, I recommend monitoring the following: her blood pressure, her heart rate, weight, height, waist circumference, nutrition status, new or worsening abdominal pain, incidence of nausea and vomiting, stool consistency and frequency, her mental well-being, any suicidality, and then the blood glucose as well. And then an A1C and her renal function should be assessed in about 4 months from now. And then those are my recommendations. Did you have any questions for me at this time? Thank you.